Okay, well, thank you guys for coming. We are going to do MythBusters for cervical collars. So we really wanted to take a few minutes and do a didactic in-service to really kind of talk about the practicality of the C collars, what we should be doing to manage these C collars, and the risks that are associated with our patients who are wearing them. So, you know, why are we here? A lot of us are here and we're going to watch this to look at how we can improve the quality of the patient care that you give. So we're going to talk a little bit about the epidemiology of the cervical collar and the pressure ulcers that our patients are at risk for. We'll talk about some current literature that's out there. We'll discuss the nursing practice guideline that's available. And we're going to review the application and care of the cervical collar. And then we'll look at some examples of some cervical collar placement. And that always gets a little fun. So how often do children have cervical spine injuries? And the answer to that is not often at all. You can see on an average, we average about 3 cervical spine injuries a year, but we do see a lot of patients with ligamentous injury. And it's these kids with ligamentous injury, which isn't really a spinal cord injury. It's really a pulled muscle in the neck. And these are a lot of the kids that we see wearing cervical collars. And you can see by this graph over the last 3 fiscal years, the number of cervical collar injuries that we've seen. There's not many, but we do consider this a never event because all of these pressure injuries are preventable if we are minding our P's and Q's and really giving the high quality care our patients deserve. Now, kids are special. Remember, they have softer muscles and fat tissue compared to adults, making them a little bit more vulnerable to some pressure ulcers. And those patients that are in our ICUs, they're overloaded with a lot of medical devices, tubes, things that are laying on the skin that really do increase their device-related pressure injury potential. Now, in 2019, there was an article, Cervical Spine Injuries in Children, that was published. It looked at the our trauma registry over 10 years. You can see they had a high N, and they had 1.5% cervical spine injuries. The upper cervical spine injuries went across all age groups and had a mortality rate of about 33%. And the lower cervical spine injuries, this is something that's seen mainly in older children as the center of gravity drops. And so we're going to see lower spine injuries more in our older kids. Now, this study did show that upper cervical spine injuries go through all groups, but the majority of your younger kids are going to fall into this category. And it's just because of that great big head and weak neck that they have. Now, our kids get cervical spine injuries by multiple ways: car crashes, they get hit by cars. Our younger kids are going to fall. Our older kids have sport-related injuries. Probably one of the most remarkable C-spine injuries that I took care of in my past when I was in the ICU. I had a little girl who was riding on a toy train at an amusement park that crashed, leaving her a C3 spinal transection. So our kids can hurt their spines in lots of different ways. That ligamentous injury often happens with the car crash or the pedestrian suck, anything that's really high energy. Other ways, non-accidental injuries, the shaken babies. As that parent shakes that baby, that neck gets jostled around, causing ligamentous injury and potential spinal cord injury. And then those in the NICU or taking care of young infants may see some spinal cord injury that happened as a result of just their birth. Common spine injuries we see AOD or the occipital dislocation. That's a lot of our younger population. These are our young kids with the great big heads, weak necks, who probably aren't in their car seat the right way. And it's usually a C1, C2 transection. You can have it as an axial dislocation. We can see axial fractures. We see subaxial injuries. We see anteroaxial rotation fixture. That's when your head can't spin the right way. And we may or may not see scora. Now that we do MRIs, the term SCORAs kind of went away a little bit. SCORA really stood for spinal cord injury without radiological assessment. And that's true when we're looking at CT and X-ray, we really can't visualize the spinal cord very well. And so we couldn't see anything with imaging. But now that our patients are going to MRI, we're able to see those ligaments and the spinal cord tissue itself within the MRI. And so that's kind of fell off the radar. So you're taking care of that patient who has a C-spine injury or potential C-spine injury. Maybe the patient's just been here for 6 to 12 hours. We haven't been able to clear the C-spine because of distracting injury or their age, their GCS is low, or maybe we've gotten a CT plus or minus the MRI that's shown ligamentous injury or an actual injury to the spine itself. So they're going to be in a C-collar, and they potentially could be in a C-collar for long term. Now we have to remember a C-collar is a medical device. As we look at it, you can see they try to help us out. They give us arrows that say front, and the side points an arrow up, so we know this is the top. And on the back, it says back. And again, there's arrows to say top and bottom. Some of the new C-collars for the older kids that we've recently gotten in, they're still the Miami J. They're a little less blue, and on the tags, they actually say Miami. We want to make sure that that's forward facing. Now, the purpose of the C.
Can I hop in really quick about that?
Yeah.
So the reason why we're even pointing out that it says like top and bottom with the arrows going up, in the heat of the moment, especially for changing these at the bedside, it is always good practice to look at what's in your hand, read it out loud, and verify that you have the front when you're putting it on the front and the back when you're putting it on the back, and that the arrows are facing up. Because sometimes if we are rushing, you can easily put these things on upside down and it happens, and you don't want to be that person. It's always good practice to like double and triple check and say it out loud.
Thank you. So the purpose of the C-collar, we keep it on to stabilize that cervical spine. We'll keep it on until the injury is diagnosed or ruled out. Once it's ruled out, we can take it off. But again, like I said, a lot of our kids are keeping them on due to that ligamentous injury, and we're just letting the muscles and the ligaments of the neck heal. So a rule out or diagnosis, how we're going to do this is we're going to look for clinical assessment look for really pain, especially on movement. We'll look for a cervical spine injury on imaging, whether it's CAT scan or MRI. Now, primary C-collar risks, depending on if you're sitting, laying, how you're positioning, your area of skin integrity risk is going to change. So just in general, when I put a C-collar on a patient, things I'm really focusing on are the ears. Are the ears caught? Are they pinned down? Making sure that they're both out and not going to be stuck within the collar itself. I look at the chin. The chin should be fit nice and snug. So it's an area that I'm going to be concerned about and provide extra padding. That chest, if you're laying down, the chest doesn't get, if you're laying down, the chest actually gets some push on it. And that's relieved a little bit as we sit our patients up. The back of the head is a vulnerability, especially when you have patients who are pretty sick in our ICUs and they're not able to turn very much. And of course, then the back, mainly those shoulder areas where that C-collar is going to sit. And we'll look at that more in depth in a little bit. Now, there's a study published in 2020, pressure injury development in a critically ill patient. Now, patients with C-collars, we know, are more likely to develop any type of pressure injury. And a lot of that's due to the fact that they're trauma patients. They may be polytrauma patients. A lot of C-collar consumers have a longer ICU stay. They're immobile, and that immobility results in less frequent repositioning, especially if you think about that patient you have in the ICU that may have the ICP that doesn't tolerate a whole lot. So we're not being as aggressive in doing some of these turning. And then when you have a C-collar on, that repositioning often requires a log roll. So it's a little bit more difficult to truly get a good reposition. So the findings in this article is that C-collar related injuries are mostly around the neck, and they found them at stage 2, and that there was indirect pressure injuries at the sacrum, And average time to pressure was 5.8 days after the patient was admitted. Another study is a medical device related pressure ulcers. This was a systematic review and meta-analysis. It looked at both adults and children. The mean ages for device related pressure ulcers in the adults were 36.2 years, but in kids it was right around 6 years old. And they estimated that the pooled incidence and prevalence of the medical device related pressure injuries, which include C-collars, was 12% and 10%, so 10% in our children. Medical device causing pressure ulcers were dwindled down to C-collars and respiratory devices. Probably, that tubing from the ventilator. Splints were another culprit, tubing devices, and IV catheters were other medical devices. And they're 2 times more likely to develop a pressure ulcer as you have more medical devices. Another article in 2019, a prevention intervention systematic review, looked at time in the collar as the #1 predictor of C-collar related injuries. And this is the reason that in the trauma service, we look at either diagnosis or collar being cleared within 72 hours of admission. Is we really are trying from a clinical assessment standpoint to get these collars off any child who doesn't need them. They also found that the injury does start to occur within 30 minutes of application of that extrication collar. Now, below you can see a picture of an extrication collar. It's not near as padded as our Miami J. And so you could see the rigidness wouldn't take long to start to be uncomfortable on a patient, especially if they're already injured with abrasions, if they're not able to move very well. It just kind of adds to that discomfort. 23% of the patients reaching the ICU with an extrication collar in place will develop a pressure ulcer. And 55% of patients in C-collars that are on greater than 5 days will develop a pressure ulcer. And that is actually consistent with the pressure ulcers we've seen develop here at Children's, is that most of our patients are developing that pressure ulcer somewhere between day 4 and day 7. So time matters. So getting that early clearance is important, or even identifying that you have an injury so we can make sure that we are truly following our protocols and our nursing practice guidelines so we can keep our patients safe if they have to remain in that cervical collar. Now, there are some patients that are going to be difficult to get that collar cleared. Those patients that have TBI or unconscious, if they're hemodynamic unstable, they're going to need an MRI in order to clear that collar. And sometimes it's difficult to get them down there within that 72 hours in order to get it cleared. So finally, another challenge that we're going to see in pediatrics really is due to the inability of our patients to communicate the fact that the collar hurts. And as you've taken care of patients in collars, we all know that they're not comfortable and that kids will complain about having them on, but are they complaining about them being on because they don't want to wear the collar and it's the collar itself? Or is it truly digging into that shoulder or putting pressure on the chin, causing that breakdown? And so our frequent assessment is going to be critical. So preventative initiatives that are found is removal of the extrication collar. Our nursing practice guideline has us do that twice a day with keeping the neck safe so we can inspect the skin, we can change the pads. We just had a patient not too long ago that was in, and he used to love when we would do a C-collar care because it meant he got a break for a little bit, and it just felt good. C-spine clearance at an early time frame for those who don't have an injury. Another good preventative intervention is exactly what we're doing now with nursing education, routine nursing care. Use of products such as the air mattress or a specialty mattress to help with some of those pressure points. We should take a multidisciplinary approach to care. This is the nurses doing routine nursing care, rolling patient, changing position, padding, but also the physicians doing their part in ordering CT, MRI, doing assessments in order to clear that collar and working with us. So as we all kind of work together, we can decrease our number of pressure injuries. So
Can I talk about this one?
Sure, go ahead.
Okay. I found this study like really interesting, and I know we're throwing a lot of literature at everybody this morning, and whenever we have anything that we notice is like considered a problem in trauma, one of the first things that we do is like go to the literature and see, like, is everybody else having this problem? Like, what are they doing? What are they seeing? And is there anything that other people are doing that is working that we're not? And when we did this review of all of this, we found that we're really, as a hospital and as a trauma service, we really are doing best practice for our patients. But this study in particular, I thought was really interesting. So the stiff neck collar that is used by EMS, and that's one of the ones that they remove immediately when they come in. Oh, sorry, the fire alarm is going off. Is it less in your office, Jen? Because I could just stop.
Yeah,
and
I don't hear it.
Okay, I'll mute myself. Go ahead.
Okay. So the stiff neck versus Philadelphia study, and Philadelphia is somewhat similar to the Miami J. So where it's not exact to us, and it's an adult study, it's pretty close, and we can extrapolate some of the findings that they have. So they looked at 60 adults who were immobilized. The participants in the study were laying down in a position for 20 minutes. So what they found is that both the stiff neck or the extrication collar and the Philly collar both left indentations or marks at least one location. The stiff neck had more indentation or marks, which makes sense when you look at just how rough it looks. Both had significantly higher temperatures, which is something we had never thought about before, is how hot does it get underneath that collar? And if you're sweating under that collar, now you have a moist skin that is going to be a breeding ground for bacteria and increase your incidence of pressure ulcers. So our conclusion, or their conclusion, and Cindy and I definitely agree, is somebody needs to design a better cervical collar, and something with, I made the comment that we probably need something like bamboo or something that can wick to keep it off. So that's going to be how we get rich, I think, is Cindy and I are going to design some collar. So do you want to talk this?
Yeah, I think it's so fascinating because in everything that we've read and everything that we've done and all the interventions that, we've been working on with C-collars for years, I don't think we ever really talked about temperature. And if anybody wants to unmute themselves and if they have any thoughts about like, what's a way that we can kind of keep the neck cool and dry. So, you have less pressure there, because if you are if it's wet and hot, you're like, it's going to just like get worse a lot faster. So if anybody has any ideas or some thoughts or about doing that, we are totally open. I think it's fascinating that we never thought about the temperature. And yes, Jen and I are going to,
one of our get rich schemes. We have a few. This that we thought was interesting too. This really looked at some of the ways that increase a patient's risk. So I'm going to try to do something I've never done, and I'm going to try to look at drawing on this as we talk. But I think about the last patient that was here at Children's that ended up with a C-collar injury, and it was only about a month ago. And when I look at this, let's see if it works. No, it didn't work. Okay. Yeah. Nope, not working. Time in a collar. He had potential ligamentous injury. He was going to be in the collar for 6 weeks. So he already hit this most significant risk factor. Excess moisture. Of course, we just talked about the fact, oh, look, it worked. Or Cindy's doing it. I'm like, oh, look what I did. Excess moisture because of sweating. He was a head injured patient. In the first few days he was here, there was a whole lot of swelling, both with face and neck. So he had edema. He had an ICP in place. And so he had, we were keeping him very sedated. So he had decreased LOC, decreased mental status. Around day 4, he also got agitated. And it was around the time he got agitated is when we found the actual pressure. So he was mechanically ventilated. He was in the ICU admission. He did have an MRI. So he met all the most common Even as we go through, he was immobile for a while. He was on pressors. I don't know what his Braden scale score was. And his injury severity score was high. So you can just see, we don't even have to go through the rest of them. You can see that this patient, along with a lot of our critically ill patients who are in C-collars, are really at a great, we have a great potential for breakdown. And honestly, the fact we had not seen more over the last 3 years really contributes to the wonderful care that people have been doing. The fact that people really do know our nursing practice guideline and are following it. So, oh, now they're still all there. Oh, okay. So it's all, the first step in preventing that collar injury is to get it right the first time. Size it up, scoop it up, and snug it up. So size it up. Everybody should be familiar with the color coding kids. And this is how we figure out what size C-collar to wear. You can find this, it's on the internet, it's on our intranet trauma page, it's on the trauma app if you've gotten it. So it's readily available if you're responsible for figuring out what size.
It's also written on the packaging of the C-collars.
There you go. Cindy, please correct me if I'm wrong. If you have a P0, that's the one that the only one that you may not have both the front and back the same size.
That's correct. So the PO collars are packaged with a P1 back. That's the only one that has a mismatch of sizing.
Every other collar size should have, if it's a P2 front, you should have a P2 back. And if you don't find that that they're working, it doesn't fit right, that really is an indication that you give somebody from our office a call, and we will be happy to come up and help with some of that fitting. Now the scoop it up, it's all about, we slide that back piece behind the neck and we flare the sides of the front out, and we're going to slide that front up the chest. So we really do scoop that neck up and get a nice solid fit. And you can see our ICU nurses here, we have them very snugly in a collar. And if we scoop it up the right way, they're not going to be able to move that neck. They're going to have to move. If they're going to turn their head, they're going to have to do it from their shoulders. And so you'll know it's good. To be honest with you, your patient should tell you that it fits snug. Now, we shouldn't be choking them. We shouldn't be doing it too tight. We want to make sure that we could fit a finger. You know, I could get something in there, but it's going to take a lot of energy to get it in. I shouldn't be able to just slide a finger in. So it should look kind of like what it does here. And then snug it up. Curl the end snugly against the child's neck and tighten those straps alternately one at a time. And so you can see how the front goes behind the back and how it kind of really snugs up. And remember, blue on blue, and the word Miami should be right side up if you see Miami on here. And again, look how snug this is fitting. These are, God love the ICU nurses. Several years ago, we did a C-collar in service in which they had to wear the C-collar throughout the whole in service because we really wanted people to know, how did it feel? So if you've never had a C-collar on and you would like the opportunity to see how a C-collar feels, we have a ton of them down here, and we are happy to let you borrow a C-collar, and so you can experience what it is your patients are experiencing. Here's just some right and wrongs. So do you want to point, you want to go through these? Some of them are obvious, but I'll be honest. Oh, I can see an A, look where his chin is. Obviously it's not snugged up there, and he's going to be able to turn his head. Now look at B, that's an improperly fit collar. Is the front upside down? Is something upside down?
So A, the tops are wrong and the bottoms are right. So in A, it's like way too loose because there's so much room underneath of the chin. And then the one underneath of it, it's nice and snug up against the chin. So I think the rule of thumb is we should never be able to see a kid's double chin. We should always have it like nice and tight up there. And then B, that's like way too loose. So, that's an airway obstruction right there. So yeah, but we have way more fun pictures that are way more interactive later. These are just the drawings that come with Miami.
Yeah. Yeah, those were kind of tough. Some of them looked like they might even be upside down. They were so wrong.
Well, don't say it now.
Happens. So if you haven't looked at it, seen it, known about it, there is a hospital C-collar guideline, a nursing practice guideline. I believe we just updated it recently. It looks at long-term. The definition of long-term is patients who are in C-collars over 72 hours. And then other definitions that are important is high risk versus low risk. Patient who is at a high risk, these are patients with known spinal cord injury or an unstable spine. So truly, we do have a cervical spine injury, and moving that patient or not supporting the neck could cause more injury. So kids that are high risk, these are mechanism injuries that we see, not limited to, but kids who dive and hit their head, causing a spinal cord injury, motor vehicle crashes, especially head-on collisions, rollovers, or ejections, or just that really high speed. The low risk patients we see are patients that the spinal cord is still intact. It's not torn or severed, but they do have an abnormal MRI. And that abnormal MRI is usually presented to us as potential for ligamentous injury. And again, it's really just sore ligaments that need a chance to stay still and heal to be able to support the head. So all patients that are in C-collars, per our nursing guideline, we should not be putting pillows under their head and neck. That is contraindicated. A pillow is going to set their head up and put them in a poor alignment. The front and the back of the collar should be the same size, except if it's a P0. If it's not, you should contact the trauma office. On admission, when we put that C-collar on, or as you admit them to the floor, you should assess the skin around and beneath the collar, because we want to document any injuries that they have. There was one patient we had not too long ago where we got a call that they had a pressure injury. And then as we went back through the records, it got to be questionable whether that was an abrasion from the initial motor vehicle crash, or was it truly a skin integrity issue that was caused here with the C-collar. And so having that baseline assessment is going to be really important. Now, every shift, we need to assess the skin integrity and beneath the collar. So we need to be able to have somebody holding C-spine and be able to take that collar down so we can get a good look at the skin. We're going to clean the area with soap and water. We'll change the collar padding because we don't want it to get, again, it's going to get sweaty and wet and stinky. And depending on what's going on, soiled. So anytime you see it soiled or wet, we might want to even do it more frequently than every shift, but at a minimum every shift. And then at handoff, we really should make sure that when we report off, we're telling the receiving nurse the last time the collar was changed. And that way we can evenly space out when we do collar care and document then any compromise in skin integrity you may know. Now, again, all patients in C-collars, side lying is the best position, and we can do different degrees of side lying to help take some pressure off. It doesn't have to be just fully on your right or your left. We want to avoid supine position if possible. Now, if they have a concurrent TBI, that may not be possible, and we may just have to live with it. But really lying on that back puts the back of that head at high risk. And then if they're moving around, they really can get into a position of comfort. But again, remember, if they're moving around, now you can have some shearing of that C-collar, so they're still not safe from pressure injury. Now, patients who are ambulatory, this pad that goes under this chest piece, if they're getting up in a chair, getting up, walking, we want to make sure that pad is in place. And so that hard plastic isn't going skin to skin. Now, intubated and trach patients do get a little tough. If they're intubated and you're doing C-collar care, consider having respiratory therapy in the room while you're doing C-collar care to help you protect the ET tube. And if you have a difficult airway or an unstable airway, don't just consider having an RT, make sure you have an RT. It is within the scope of nursing practice guidelines that we should not be doing that without an RT. If you have a trach patient, we probably need to get our trauma up there as well as a tracheotomy nurse specialist. And we all should look at this together to look at the best fit and how this is going to work with a trach patient. There's been a handful over the years, not many. And usually we can figure out how to make that work. Now, the nurse practice guideline now then separates out low risk versus high risk when we are preparing to do C-collar care and doing C-collar care. We have a patient with low risk, those kids with potential ligamentous injury. You can do it with 2 RNs, and you have to have at least 2 RNs. If you got a third, great, but 2 RNs, one to hold C-spine and keep their head and neck in line and not moving. And the other nurse is going to do the skin assessment and do the skin care and change the pads. So nurse 1, you stand at the top of the bed, you're holding the shoulders and keeping the head in line, and you're not moving. Nurse 2 is going to do all the other work. And then weekly, somebody from the trauma office or the skin team is going to come up and assess the patient with you, looking at collar fit and also doing another skin integrity. And it's a great time if you have questions that you can ask. Right now, we're saying weekly we'll do that. We're actually trying to come up at least twice a week. And that way we can make sure that any questions you have are answered or any problems are dealt with. The supplies you're going to need is a second C-collar. It's just easier to change out a whole C-collar versus take one off and change pads and put the initial back on. So you can do it a little quicker. Get some foam barrier, whether that's Mepilex border and or Elastigel. And what you're seeing there is a picture of Elastigel. Get some soap and warm water and a washcloth then to clean the skin. Now for these low risk patients, we're going to apply the C-collar care, for all patients, plus put the foam border dressing, and we're going to put that on the chin, the shoulders, the back of the head. And you really want to look to make sure where you're putting this is truly where the plastic or the hard part of the C-collar is going to come in contact. Often I've come up and Mepilex border's been on, but it's been in places that really aren't doing me any good. You want to assess the skin beneath the foam border. And if necessary, go ahead and change that pad. Usually I leave that foam border on for a couple days unless it's soiled or wet, and I'll just pick it up and look underneath and put it back on. And then as far as when to change it, it says you can change it once a week, but again, I tend to do it every few days because it does kind of get loose or wet because we're picking it up and putting it on. That tape just doesn't last a week, but that's what the nursing guideline says. And then our patients that are at high risk, remember, these are patients that do have a spinal cord injury. And so keeping that C-spine in line, keeping that head still and that neck still is going to be critical when we do our C-collar care. So for a high-risk patient, you need at least 3 RNs at a minimum. And again, if you have a vent or if your patient's intubated, go ahead and have RT pop in there with you. So the first RN, just like in the low risk, is going to be in charge of C-spine stabilization when that collar is removed. RN2 is going to perform the skin assessment and do skin care and pad changes on the right side of the bed. And the third RN is going to do the exact same thing on the left side of the bed. And so we have RN2 and 3 both working on their respective sides, so we can kind of take care of this in a quick and efficient manner with very little movement of the patient. And again, trauma will come up at least once a week, probably more frequently with this patient. Same types of supplies that you needed as we did with the low risk patients. And so all collar care for all patients. Consider putting them on a specialty bed within 24-hour admission or when it's convenient. If they have to go to the OR, that's a great time to move the bed. A lot of this comes down to patient acuity is when we can put them on that specialty bed, but a dolphin bed is a great option, not only to keep your patients safe from C-collar related injuries, but all pressure injuries on that really sick child. Just like in the low risk, we're going to apply that foam border dressing. I am a big fan of the Elastigel. If you've played with that Elastigel, it has a lot of give and take and really can protect those pressure points really well. And remember, we're going to assess beneath the foam border dressing with skin assessment and pad change twice a day, so at least once a shift. And the same, change the border at least once a week, but if it's soiled or wet. And then reportable conditions. Anytime you do your C-collar care, if it's red, if it's irritated, if it just doesn't look right, you're a little worried about it, go ahead and give the wound team a call. So trauma will take care and help with a lot of the C-collar care, But the minute we start having any type of integrity breakdown of the skin, that's when we want to get the wound team involved, because even if it's just a little red, that they might have some ideas and thoughts that we can prevent it from getting any worse. Other reportable conditions: if the C-collar size isn't consistent with the package recommendations, give the trauma team a call. Those packaging recommendations really look at age, and for the most part, they're pretty on target. But every once in a while, you do have that really big or really small child per age that we may have to adjust. And then other reportable conditions: if the patient's able to turn his head while in the C-collar, obviously it's not fitting well, and please feel free to reach out to the trauma team and we will help you find the right size collar if you're having difficulties. So Cindy, I'm going to pass this on to you. You just want me to click, or do you want me to share? You're muted.
If you just unshare and then I'll reshare. So right now, we're about halfway through. We're a little bit more than halfway through. Does anybody have any questions before we move on? Because this is getting to the interactive part of our thing. I'll give and you can use the chat as well.
Hey, Cindy, this is Megan Crandall. I have a question.
Hey. Yes.
And I think maybe I've asked you guys somewhat before, but is there any kind of policy or protocol as to when you move somebody with a C-collar, like is it policy to have somebody solely like supporting the head and the neck? There's been some issues where, clearly if like a high suspicion injury, like, yes, that makes sense. But you have kids that sometimes are in these collars and the ambulatory, and I had a CT tech refuse to slide the patient over, just him and I, because we didn't have anybody for C-spine, like doing that. But I'm like, the collar seems to be immobilizing it. Why do we need somebody? So I just was curious your thoughts.
First off, that's a great question. And I feel like it's one that has perplexed everyone in this hospital for quite some time. So the ER is probably the trickiest point because we don't know what the injury is yet. Jen, do you want to answer how it should be handled?
It's going to be probably patient dependent, but I agree. The ER is the tough part because we probably haven't been to CT yet and we haven't been to MRI. And I would say if you have the collar on, it's fitting well. I always like to have somebody at the head just because it's at the head. If the C collar is on well, you should be able to just kind of help support it over. But I mean, if it's you and a CT tech and one of you at the head and one of you is at the body and you have a young child, I think the two of you could easily do it yourselves. It's the older child that probably needs that third person, and not so much even for the C collar, just for the movement itself. So I would say somebody should always be watching the head of our patients, and the C collar can really help hold the neck. I don't know, Megan, did that help? I feel like I just talked around it a little bit.
Yeah, no, I think, that is, that summarizes kind of my thoughts as well. I just didn't know if it was like, at some point somebody had thrown it in some like,
No, that gets to be
policy I could bring up to them, but it's,
it would be nice to bring it to them, but that's one of those things that's hard to put in black and white because, a 6-month-old is different than a 16-year-old.
Exactly.
And putting that in black and white is just really tough. So.
Yeah, and that makes good sense. I just figured I'd give it a shot.
Good try.
Did you see how quickly I punted that definite answer? I was like,
that's awesome.
Sure. Okay. Sorry, I was having some issues with my PowerPoint on my end. So feel free to unmute yourselves because I really would like to make this a little bit more interactive. And the rest of the presentation is all going to be pictures. So yay. Okay, so what size C collar do you think she's wearing? And by the way, this is a 22-year-old female. Oops. Any thoughts? And Jen, you can guess too.
Well, I'd have to, I'm going to the app so I can look at the sizes.
Oh.
I'm going to throw it out though. I'm going to say P3.
Okay, so this I think is a great time to say that the normal sizes for kids are, we have the papoose, and we have P0, P1, P2, and P3. But also, if you have a patient who is older or who is really tall or has a really short squatty neck, there's a lot of different sizes available. So if you have a patient that doesn't fit in a particular size, that is when you can call the trauma team and we can get that. So although we just talked about like PO, P1, P2, P3, there is one called short, there is one called tall, there is one called, oh gosh, there's another one too. So there are other options, but the P collars are the ones that we have the most available and fit 95% of our kids. So Liz Weibel is right.
Oh, hold on though. But the app actually shows for her, the fact that she is an adult female, that a 400 regular would be another size that you could choose for her.
Okay. And what is interesting is that the P3, go ahead, Liz.
Well, I was also going to say, you really just have to, yes, she's in and I know who this person is. So in the back of my mind, yeah, she probably fits into a P3. But I think the important thing is we shouldn't get too hung up on the labels, right? You should look at the proper fit, like Cindy had mentioned. It should fit properly under the jaw. So again, it's really just how stable the patient is in it as well.
So yeah, and it's interesting that most adults will fit pretty easily in a P3. And then my next question is this a correct fit or incorrect fit? Like, is it put on correctly? Like, is it, facing the right way? We have the front on the front, the back on the back. Anything in the way? I'm really bad about waiting appropriate amount of time, but I'm going to wait.
Yeah, it looks good.
Yes. Yeah. So this is a P3 collar and it is, it's put on correctly and it fits correctly. Okay. So same girl. So it's still a P3. And I think we all can tell what is wrong with it. I mean, we all can tell it's on incorrectly. But could somebody either type in or unmute yourself and say what's wrong with this collar? Okay, so we have an answer from the chat that says the front is on the back and the back is on the front. So yes, 100%. So this is the back and this is the front and they are flip-flopped. So one thing that most of our C colors, you can kind of tell like quickly what is the front and what is the back, other than just reading it where it says front and back. But if you think about if a patient has a trach and they're in a C collar, well, first off, they're having a pretty bad day. But second off, if you had a patient that had a trach that needed a C collar, where would the trach go if you put the back on? Like there's just nowhere for it to go. But here you would have, I always say like that's the airway hole. So yes, so still a P3, but put on incorrectly with the back on the front. Okay, so this is also a P3 on an adult in their 20s. Is this on correct or incorrect? And you can put it in the chat. Okay, so somebody wrote in the chat that it is on correctly, and that is, yes, this is correct. You can tell like the front is in the front, the back is in the back, the arrows are pointing up. We have nice blue on blue. Since she is standing and sitting up, you can still see the chest pad is on. So one thing we have to remember when we're putting, when we have C-collars on our supine patients that aren't moving around, they have that chest pad that has to be removed if they are staying supine. The emergency room, when they first place them on, all of those kids are supine. They don't remove that chest pad because they don't want it to get lost. So if you are admitting a patient from the emergency room to surgical care or the ICU, just remember to remove that, that chest pad, because that's an additional pressure point that is going to cause issues later on down the road. But once a patient is up and can walk around and sit up with that C-collar on, you got to put that chest pad back on for stabilization. Okay. Okay, so this is easy. Is this incorrect or correct? And why is it incorrect? Because I feel like everyone can tell that it's incorrect. What is wrong with this collar? Okay, perfect. Thank you so much for saying that. The front is on the front, but it's upside down. So we have the front on the front, which is, you know, one step, but it is upside down. So this is not stabilizing her spine whatsoever. So the back's on properly, but the front is on upside down. So there's no scoop to her chin. There's no support. All right, how about here? Is this, what is incorrect about this photo? Okay, we have somebody with saying that the size is too big. Any other thoughts? So the size here looks pretty good. So you can see like there's a nice fit around her face. The back, maybe, but the problem is that you can't really get a good look at the collar. We can't get a good look at the collar because her hair's in the way. So our kiddos with long hair, we have to make sure that the hair is pulled up and away from the collar so we can get a good fit, make sure that the collar isn't too big, and be able to continually evaluate it. Plus, this is just a recipe for disaster. We're not going to be able to assess anything because even if we are like, and then when we're moving the collar, we're going to pull hair. It's just going to be a mess. So our kiddos with longer hair, we just need to make sure that the hair is out of the way when we're putting on a collar or replacing a collar. Okay. And then, and this one, definitely wrong. But what's wrong with this picture? So this one, nice fit in the front, but the back is on upside down. And if you really look at this, you can see the arrows are pointing down. The arrows should never point down. Arrows should always point up. Okay. So the next slides are some things that we have seen in our hospital. And my thought is just don't be these people. And if you see this, fix it. So obviously this guy is a little bit too old to be a patient in our hospital, but I saw this on when I was Google image searching C-collars, and it made me laugh. Okay, so this little kiddo had just come back from the operating room and had a procedure. You can see like there's some wires that are inside of the collar. It's obviously not fitting appropriately, but what else is a big problem? Like, what do we see right here that is a huge problem? Yes, 100%. Yeah, the airway is compromised, right? Because the collar's in the airway. The chin part of the collar is like way above the chin. Like I'm not even quite sure that this is the right size of collar for the patient. So if you have a patient that comes back to you and this happens, please don't let this happen. Yeah, there's so many problems with this. It's not the right size. We have wires wrapped in with the straps. The chin isn't supported at all. This isn't doing anything for the neck, but blocking the, but it is blocking the airway. So we don't like that. Okay, so in this picture, you can see that a collar was just placed on this little kiddo. And as you can see, the front is on the front, but it is upside down. So again, this is not proper placement. But luckily enough, they were able to fix it and got the collar put on properly. Now, this was caught immediately, and we were able to catch it on video review because the collar was placed by a provider, and our nursing staff said, "Hey, that's upside down. Let's fix it." And they were able to fix it before the patient left the code room, which is exactly what should happen. So if you see somebody putting any type of medical device on, and I think that's one thing that we need to start thinking about C-collars. It's not just a C-collar, it's a medical device. And if you saw somebody putting an IV in wrong, surely you would say something. We have to think about C-collars the same way because they are devices and they can cause issues when not applied and taken care of properly. So this is like a perfect example of a nurse stepping in and saying like, "Hey, that doesn't look right. Let's fix it." In this case, it didn't go as well. So, so what's going on? What's wrong in this photo? And feel free to unmute yourself or put it in the chat. Okay, so the back's on the front. Like there's no airway hole. So this kiddo fell from a couple stories up and was completely like had no injuries, thank goodness. And he was placed in a C-collar for precautions. Here's the side view. Does that I know that it's very pixelated, but does this look like it is giving support at all to any part of the neck? Absolutely not. And after a couple hours of not really having any complaints, he started saying that his neck hurt. And his neck hurt because the collar was on wrong. Next picture. This is a provider putting starting to put on a C-collar and putting on the back first, but again was stopped and said like, "Hey, it's not the back, so we don't want the back on the front." And then was able to place the front on the front and the back on the back. But again, even though this is quite pixelated, and apparently I just got notification that my internet connection was unstable, so that's not helping. But you can easily see that the sides are like flared out and they're supposed to be like nice and snug around the neck, and you're supposed to have blue on blue without making any type of crosses. So you can see like there's like an X on this side, little X on that side, and it's flared out. So that's also incorrect. So, but then about a minute later, it was perfect. So we went from having the back in the wrong spot, then putting the front in the right spot, but not properly. And then finally, this is a great collar fit for this child. Okay, so a little bit about the papoose. What is going on with this picture? What is wrong? And I'm going to wait for somebody to say this one because this one's an important one. Please tell me what is wrong with this photo. Okay, perfect. The head part of the collar is below the head, 100%. So the head is supposed to go right here. This little spot right here, this is for the ears, not the arms. So And it can be tricky because when the papoose comes out of the packaging, the collar part is actually attached right where the head goes. And I think that's confusing for providers, for nursing, for anybody who's even opening up the package. But just to remember that little part right here, that's for the ears. And this larger part right here is for the arms. But I can see how this happens because the baby does fit nicely into the papoose this way, but it doesn't do anything at all for the spine. I mean, you can see like he's like hyperflex and this is like covering his face. It's an airway obstruction. There's all sorts of wrong going on with this photo, but I think it's an important one to share because we definitely do not want to do this. So again, like this is where the ears go. We started using a baby doll whenever we are training our surgical residents about how to put this papoose on, because we noticed the way that the Miami J, the way they're packaging, again, puts the front of the collar part like right on the head. So it makes it look like this is how you're supposed to apply it once you take it out of the package, but that's not correct. The front of the collar where the neck is goes where the baby's neck goes. So head, neck, torso. So again, this is where the ears go. And you want to have like blue on blue. And this is the head strap. This is not a neck strap. I've also seen this, the strap of the head like wrapped around the neck. That is, yes, it may keep the front of that collar in place, but it's not appropriate. And it's also a choking hazard. And again, like here's the ears. And this is baby Holly. This is who we use to train all of our surgical residents now. Because when our surgical residents come, this is sometimes their very first rotation ever taking care of kids. So they've never even seen a papoose or a small C-collar before. And, you know, it's important for us to show them like some of these subtle things, especially when it comes packaged with the neck piece up here. And as Jen was talking to you earlier, these guys are your best friends. So we have the Elastigel and this is the Mepilex border. These are going to save you. These are going to save your kids from any type of pressure ulcer. And then I have a really super complicated algorithm that I thought would be fun to share. And this is how we do cervical spine clearance. And the one thing that we got from like all of the papers that we researched to do this talk today was like the number one thing was getting the collar off. And that is why we have this like very large dedicated algorithm to getting the collar off. And so if you ever are taking care of a patient that's in a C-collar and you are like, does this kid really need to be in one? And you think that they've been in it for too long, call the trauma team and, you know, make sure that we haven't missed anything. Or if you have questions of like, why is the kid still in the C-collar? Like any of us would be happy to look at the patient with you and make sure that we're not missing anything. Thank you guys so much for joining today. And I'm going to hold on one second.